what time it is. Marvin Devine, Huber, Axel, and you know how we do. Yeah, I got the juice, yeah, I got the juice. Whip game cool, make them look like cool. Always play it cool, that's the biggest rule. Forget what they doing, keep on doing. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, wanna get in my crew, but you can't get in my crew. Me, XL, and Huber, way too fireable. When this joint drop, better call the troops. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens when we link up. Let's go. Yeah, I got
Good evening, and good afternoon, wherever you're watching from. Thank you. Thank you for tuning in for another broadcast of Kidney Hub East Africa. I am half your host, Steve the Kidney Nurse. Today, we have a show that impacts, or let me take that back. We have a topic that impacts everyone affected by kidney failure. That is the process of getting an AV fistula or AV graft, hemodialysis access. And what AV means is arteriovenous fistula or arteriovenous graft. Now, here with me to talk about this very important topic, as he is every week, relentlessly, is our brother from Kisumu, Kenya, kidney warrior and advocate, the kidney ambassador, Brother Moses Kennedy. Let's give him the VIP intro. Brother Moses, can you hear me?
Yes, Brother Steve.
How are you doing today?
You. I'm great, Brother Steve.
Good.
I'm great. We had good rains, heavy ones, of course. And I had to maneuver all the ways to make it where I am now. I'm glad you've made this show alive today again, once more. So thank you much. Thank you so much on your part.
Oh, absolutely, brother. Absolutely. And it sounds like you may be experiencing some internet connection because you have frozen, but I can still hear you. Okay. Can you still hear me? Brother Moses, are you still with us?
Can you hear me?
Yes.
Oh, you are frozen on your side.
Okay, so it looks like we're having some internet issues,
Seems
but
you are frozen on your side.
okay.
Hello, brother Steve.
Yes, I'm here.
Yeah, can you hear me?
Yes, I can.
Oh my goodness. Uh,
So let me drop him and let's get started with the show because this is very important and we'll bring Brother Moses back up in a second. But as I said, this topic, the process of a hemodialysis, of receiving a hemodialysis fistula or graft, impacts every kidney warrior that starts dialysis because you have to have a lifeline or access to the blood in order to start treatment. Okay, now before I get started, let's see if Brother Moses has corrected his issue. Brother Moses, can you hear me? Can you hear me, Brother Moses?
I can't hear you.
Okay, I'm started the
I
show,
can't
so
hear you.
okay, just stand by. I'm going to continue the show, okay? All right. So, as I was saying, there's a process when one has to receive an access. So, what normally happens, the person is diagnosed with kidney failure. And depending on the person's situation, doctor said, we got to start dialysis. Your numbers are through the roof. So soon as that happens, the first thing that they may put in, if they need to do emergency dialysis, like get to it right away, they're going to start off with the IJ. Okay, they're going to start off with the IJ. Most places will start off with the IJ. And that goes on the side of your neck in the jugular vein. And this is quick, easy. And as you can see, it has a red port and a blue port. The red port pulls the blood out and it goes through the filter. And then the clean blood comes back through the blue port or the venous side. The red side is the arterial side. That stands for artery. Okay. So once they have that in, once they get a person stabilized, if they put this in first, then they move to put the hemodialysis catheter in. Okay. And this is the one that goes right here in the subclavian vein. You either go on the left or right side. And it has the same ports, a red and a blue. Red. The only difference with this one is it's much longer, and it goes, the tip of this is in the back of the heart. Okay. Now, let me bring back Brother Moses. Brother Moses, can you hear me? Can you hear me, Brother Moses? Okay. So again, it seems like we're having some technical issues. I want to let him get that straight. But once this catheter is in, a lot of people are very comfortable having this. But it's some risk to having this, okay? There are some risks of having this catheter. So once a person is stabilized, and go to their outpatient dialysis center, someone normally comes to them at some point in time, or your family member, and they say, we set up an appointment for you to go see some surgeon. And you don't even know who the surgeon is. You don't know who the surgeon is. And most people go to the surgeon. But let me stop right there. I encourage you, if you're about to start your family member and they suggest a surgeon, I will look up another vascular surgeon so you can get two opinions. Not just one, but two surgical vascular opinions on what's about to happen. And so let's start at what happens. One is the evaluation. You got to get evaluated to see if your veins are able to handle getting an arteriovenous fistula or graft. Brother Moses, can you hear me?
I can hear you.
Good, good.
It's frozen on your side, yeah.
All right, don't worry about that. You can hear me, right? Can you hear me, Brother Moses?
I can hear you, but at times it froze. I can hear you now.
Okay. I'm going to put you on mute and continue because I don't want to slow the show down and keep going back and forth and trying to resolve the issue, okay?
All right.
And I'll come back to you in a minute and ask you some questions to see if we can hear you. Okay. So the first part of this is the evaluation. This is when the patient goes to see if they're suitable. The suitability for an AV fistula or AV graft creation, which is assessed by the vascular surgeon. They're going to have to look at factors such as the patient's overall health, the blood vessel conditions, which is vein mapping, and previous access sites are taken in consideration if they had this done before. But the first step is vein mapping, the evaluation, and that's where surgeons look at your veins, and they'll normally use the non-dominant arm, and they look at your veins. Especially if you had diabetes and had diabetes long-term for years, you'll find people with diabetes have small veins, as many people of color have small veins. And you go to the surgeon and they look at it and say, your veins are small, but I think we can manage to do something. And so then that's where the preoperative assessment come into play. Before the procedure, the patient undergoes various tests. Get your blood test, imaging, like I was saying, the vein mapping, Doppler, vascular mapping, to determine the best location to put an AV graft or fistula. Now, I'm going to put up for a moment a picture of how this looks. And if you're on, you can't see this on TikTok, okay? But let me see something. If you can see, you have an AV fistula, right, versus an All right, guys, I'm back. Sorry about that. But as you can see, you have the AV fistula versus the AV graft. Now, on the top picture is the AV fistula. As you can see, the artery and that blue vein are surgically connected together to create a large vein, so you can cannulate it with a needle. Then you have a straight graft. You can see the plastic, the white piece here. And then on the bottom, you have a loop graft. And now let me tell you, the graft is a man-made material. The fistula is using your own veins. The graft is using a synthetic type of material, which is man-made. So there's a look at it. And then we have the fist. Here we go, another example of a fistula, the top picture, where the artery and vein is sewn together. And then the bottom one, you had a graft, which is a loop graft, where each piece, each end is connected. One is connected to an artery, and the other one is connected to a vein of the graft. So that's the difference. Brother Moses, are you with us?
I'm in, Brother Steve.
Okay. Can you talk about if you had any experience on getting a fistula or a graft?
Oh, yes. Initially, when I first got the catheter, I was told that I should be getting a fistula as soon as possible. and because of other constraint, I decided to use a catheter for some time. That is like almost a year. Then I went in for a review, and then thereafter the mapping was done, and then I had the surgeon made the fistula on my left arm, and then it failed. It never matured, and then I continued using catheter. I got demoralized, after which spending money out of my pocket to book appointment to see vascular surgeon. And the process of doing that here in Kenya is actually an uphill task. So when I decided again to stay because it failed, it never matured, I went back for a review. The surgeon told me that normally maturity rate is 40 to 50% here in Kenya. That is what I was told. And then I decided again to recollect myself. And again, I went in and they tried my right arm. And you know what happened? Fortunately enough, it got matured. And then I used it for 2 weeks. Then I had transferred to another treatment center. Thereafter, a newly nurse that was brought in punctured it. Now, when it got punctured, it got spoiled. I didn't know that fistula can get punctured. So when I made the complaint, the facility decided to assist me try another one. Now, when it was tried, it never worked. So that became the end of it. Thereafter, again, I used it for 2 years. Then, after also learning several advantages about fistula, including a better outcome compared to catheter, chest catheter, I decided to visit again to seek second opinion. I was told that my veins are narrow, that now what I need best is AV graft. But I stopped there because the cost was also skyrocketing. Now, Brother Steve, I've had my catheter for almost 6.5 years, but I'm careful with it. However,
Wait a minute. You had your catheter 6.5 years?
Yes. Because on my 4th year on dialysis, I had planned to have a graft. Then I was given a quotation. When I went in, I was told that the cost of doing surgery, putting in that graft was high. So that is how it became the end of the road.
Let me, Brother Moses.
Yes.
I'm sorry. Let me interrupt you right there for a moment. And
No
see,
worries.
this is the part that a lot of people don't understand. In Kenya, they have to pay for anything that the National Health Service doesn't cover. Their insurance is not like Medicare, where over here, Medicare pays 80% of the cost. 80%, leaving the person only with 20%, and they may have some secondary insurance that will cover that 20%. Unfortunately, with Brother Moses, if he wants to get a graft, he has to come out of his pocket.
Absolutely true.
And if he want to, and with the fistula, he had to keep going back and getting it worked on. I'm sure that had to come out of his pocket as well. So this is why we do these shows, because if you're in East Africa, Kenya, and you're not making a lot of money, and you may be on the road to kidney disease or failure, we want to give you information that is evidence-based, that you may use to help avoid some of this. So again, if you're diagnosed and they want you to go see a surgeon, tell them you want to get a second opinion. So you can talk to 2 different surgeons and find out what's going on. And see, unfortunately, Brother Moses and our fellow warriors in Kenya and possibly in the rest of East Africa don't have this opportunity. Maybe some people do who are able to afford it. So continue, Brother Moses, about your access before we move on to the surgical procedure of this.
Thank you. So, Brother Steve, when I had gone to seek a second opinion, the quotation was far much higher than what I expected. I decided to go home and continue using catheter, and I decided that now, when times come and money, one day I'll have a graft done. So that is how I've ended up using my catheter for that long. However, I've had several infections that I've treated, and I'm still going on one day at a time. That is why I cannot do anything about it.
Brother Moses, Tabitha, she says our National Hospital Insurance Fund pays for fistula and graft in many hospitals. Can you speak about that?
Oh yes, the situation here is completely the reverse. Our National Hospital Insurance Fund pays for a small package that does not include fixing of catheter, fistula, or any other form of access. So such expenses must come out of your pocket, my dear sister. So it takes a big heart, it takes a lion's heart, to fight as a warrior here in Kenya. And I represent many of them that have reached the end of the road. in various spheres in their lives regarding kidney failure. There are people who are even have a point image maybe a CT scan for the heart. They have been sent to go for CT scan for the heart. They can't breathe, and then they definitely lose it, because now the few nephrologists we have here, they also have nothing to do about it because their hands are tied up. So that is how most of them end up losing. Like last week, we lost about 5 that I've known, 2 though different in different facilities where I am, but because of we network, we lost them.
You lost
So
what, 5 kidney doctors?
I mean, 5 kidney warriors.
You lost 5 patients.
Yes, not in my unit, but different places. Different places. Yes.
Oh, I'm sorry to hear that.
Yeah. So that is the situation, Brother Steve. That is the reality.
Right, right.
Yeah.
Okay, let's talk about the surgical procedure, because this is the important part when you get an access, is the surgical procedure. So one should be, when you go to see a surgeon to get evaluated for access, you should be asking questions such as, do I have small veins? And they say yes. Well, before you even do that, you should be interviewing, meaning how many surgeries, successful surgeries, have you done? How many repairs have you had to do? Meaning people had to come back and get surgical repair. You know, what's your success rate? And then move on to asking questions about your veins. Do I have small veins? And ask them, if they say yes, ask them, can they go up top? Because again, here's where you come into a matter of opinion. Some people say, don't start up here, because if you start up here, don't work, they don't go down. And then others say start down here, because if it doesn't work, you can go up. All right. Now, if your veins are small down here, they are much larger up here. I showed a picture of the large veins that's up here. What if you start up here, the chances of it failing, in my opinion, are going to be much lower than if you start down here. Now, that doesn't mean that if you get surgery up here that it may not work. Everybody is different in their vascular system. But before you get all these cuts, you want to make sure you talk to the surgeon and ask questions and don't just go along of what they say. We had a comment. Tabitha said, Brother Moses, catheter you buy fixing the catheter, NHIF pays, especially government hospital. Are you familiar with that? What she's saying?
Yes, Tabitha. Yes, Tabitha. Let me clarify something. Maybe as a patient, yes, Tabitha. There is when you go to vascular surgeon, you must book appointment. Number one, you must book appointment for the surgery. Normally, it only pays. You can request pre-auth before that kind of surgery is done when there is a medical camp. It happens that way. But here is a case, how long will you wait for a medical camp? You know, because such cases are few. What happens is that when you want to have a fistula, you have to book an appointment with the doctor. You are scheduled, you know, they don't just come and do it. You must schedule first. Then you are told we can have this kind of appointment. Then you are assessed. Thereafter, you are assessed. You are given an appointment again to come for the surgery. Now, if there is no camp, I'm telling you what is on the ground. If there is no camp, then you will definitely have to pay out of your pocket. I was told my veins are narrow. I went to Kenyatta National Hospital and I was told my veins are narrow. I did a venogram and I was told also that my veins need to be ballooned. Okay, yeah, to be ballooned so that they become much better before the AV graft is fixed. Now, I want to ask Tabitha if he knows any doctor he can refer me so that I can go. I'll be really happy to have my graft fixed and paid with my NHF. So it comes out of my pocket. Yes, you will hear people say NHF pay, but I'm telling you as a patient experience, NHF does not pay for that. It doesn't pay for that.
Wow.
Yes.
That's wow.
I think,
okay.
Yeah. So
interesting to hear.
Yeah. So Tabitha, just get it right. I know people say that the catheter you get paid for. I mean, you get paid for by NHF. It doesn't work that way. It can only be paid by NHF when you go to a referral hospital, Kenyatta National Hospital, which is crowded. I remember one day I'd gone there for MRI. Then I was told to come next month, you know, because of the long queue. Being a referral hospital, there are so many, the traffic is high. So that is what happened. At referral hospital, yes, it can happen because that is a referral hospital. But then the challenge is, how many of us are moving there? And remember, it is not only a renal patient that goes to a referral hospital. So it becomes a challenge. Okay. Yeah. But if it is a medical emergency, NHF paid that, the cover allows that. As an inpatient, it pays.
Okay.
So
let's talk
something very controversial, and it's really very controversial.
Okay, so let's talk about the surgical procedure. The AVF and the arterial. Let me put this picture back up so one can get an understanding of what we're talking about. Here we go. So the AVF and the AVG, meaning the AVF is the arteriovenous fistula, which is the top one, and the AVG, arteriovenous graft, is the bottom picture. Creation is performed in the operating room or maybe an interventional radiologist suite. Okay. And what happens, the surgeon makes an incision in the arm to access the blood vessels. And if you can see in this top picture how they sewed the artery and vein together. Okay. Now, for an AV fistula, again, the surgeon connects an artery to a vein directly, while for an AVG or arteriovenous graft, a synthetic tube graft is used to connect the artery, which you can see in the second picture. And you got 1, 2 going into the red vein, with that red vein, then the other one going into the blue one. And that's how the blood goes through that graft. Now, Brother Moses, did you know this about the graft, how it was made and what it was? And let me just say that with the AV fistula is the access of choice. That's what they want because it's using your natural veins. Now, there's advantages and disadvantages to each access. Now, if you can't get a fistula because if your veins are small, then they're going to recommend a graft. Now, on the average, most grafts have a 5 to 6 year usage. Meaning once it stops, working, after that, you're going to have to get another one. Because you got to imagine, for 5 or 6 years, 3 times a week, that material is getting punctured. Now, what one has to remember, in order to have that access for longevity usage, you're going to have to rotate where you put the needles. And this is where the issue comes in, where if you go to dialysis and you don't say nothing and you just let the staff stick you wherever they want, they're going to go where it's easy for them. And so you go right there, easy. And what happens if you keep sticking in that area, if you look at this material, that tubing, each time you stick it and pull a needle out, it's supposed to seal, clot out with the blood. But when you go into an area continuously, it's not going to be able to close. And you can Google failed grafts. And if you could take the image You seeing them taking out the accesses all mangled up. You got some people that had a graft. You got to watch out with the healthcare person sticking you, because if they're not using infection control protocol, implementing that, like washing their hands, changing the gloves, cleaning your access really well. And you know, patient has to play a role in that too. When you go to dialysis, make sure you're washing your access with the microbial soap. When you're at home, cleaning it twice a day, in the morning and the evening. Because with grafts, they more prone to get infected because it's a man-made material than the fistula. And with some people, they had to have the graft pulled out because it was infected. The next thing you know, you don't want to get sepsis or get septic. Brother Moses, you want to chime in, or anything that you want to say about the surgical process or procedure that I mentioned about the AV fistula or AV graft creation?
Oh, yeah. Oh, yes. You know, getting AV graft sometimes sometimes becomes a very interesting process, because just allow me to talk about the process. Because number one, you must, your nephrologist who takes care of you must recommend, number one, that you need a fistula, and because most patients do not know that catheters are meant to be used temporarily. Myself, initially, I didn't know. 5 years ago, I didn't know that catheters are meant to be temporary, that fistulas are the best access to have. So, because of the ignorance that normally comes in, patients do not know that the best access is AV fistula. Now, you continue using chest catheter until when one day the doctor tells you that you need a fistula. But you know, sometimes what happens, the nephrologists, because they are few with their busy schedule, sometimes they will not tell you unless you begin that conversation. They know that sometimes, even if they tell you that, you might not, owing in mind that the challenges in having it done is there, you know, Steve. So when one knows the importance, then you seek now the process of getting one. You book appointment, you pay for consultation fee, you are scheduled. After that, a surgery is done after payment. Payment at NHF, at Kenyatta National Hospital, can happen with NHF if it is a medical emergency, just like any other emergency. Not that NHF pays for fistula. No. Yes, it will pay just like any other emergency, medical emergency, when you are referred at Kenyatta National Hospital and you have your valid national hospital insurance, if your account as at the NHF is up to date, you can have it just like any other medical emergency. Now, number 2 case that NHF can pay for fistula, but not graft. Graft is completely out of place. In either way, it doesn't pay. Now, number 2 way that NHF can pay is when a team of surgeons organize some camp and they are moving, rotating around the country. That one at one time happens maybe once a while. Now, everyone is covered through that NHF. That is number 2 case when NHF can work. So I'm just putting it clear for warriors out there to know that is the state of the NHF. So that is why I'm speaking with a lot of authority. That is the state at NHF. So you pay the cash, you are done outpatient, and you go home. So it is not something you just come that you want to have your access. How long will you wait for the medical camp? You also wait for medical emergency so that you are rushed into Kenyatta. So that is why I'm saying it doesn't pay, Brother Steve.
Okay.
So this is why I'm making clarity to Tabitha, my sister.
Okay. Thank you for sharing that. So after the surgical procedure, once they do the AV fistula or AV graft, then you have post-operative care, right? Following the surgery. You know, they monitor you for complications such as bleeding, infection, or thrombosis, which is another name for clotting. And so that's why they tell you after surgery, your arm is wrapped. Normally the surgeon makes sure that you have a thrill and a bruit in your arm, meaning you feel the blood coming through, and then you can also hear it. That lets you know that it's working, that it's open. And so most of the time when you go home, they'll tell you to prop your arm up. Don't sleep on it. Because if you sleep on that side of your arm, what can happen is you can compress it. You can compress the access, and there's no blood flowing through. And then it'll stop, or it can stop and form a clot. Then you got to go back, get that process declotted. But if you have an access post-operative care, normally after 24 hours, you're able to remove the bandage. Then you see the work that they did. Got that film on it, and maybe a gauze. It may look bloody. When you go to the dialysis center, technically they're supposed to change it, take take the old bandage and clean it up for you. And then that's if you got an AV fistula, which is they using your own veins. That's what you do what Tabitha had mentioned. You tell the patients, we advise, Tabitha said they advise their patients to exercise the hand, not to lift heavy objects, not putting any blood pressure cuff around it, no blood draws, and not to use it for any physical labor. But you want to exercise it with the use. Maybe they may give you something like this, a ball, exercise ball that you squeeze. And the purpose of this is to help dilate the veins, build the veins. Sometimes with some patients, you can find yourself a light tourniquet and not put it on tight, but lightly, and keep it on for a little, maybe 2 or 3 minutes, and squeeze the ball, and the tourniquet helps dilate. But if you got small veins, you may be defeating the purpose, because you may not can even build the veins because the veins are small. So post-operative care, if you're about to get something like this done or it's in the future, make sure after you leave that surgeon's office, you get the instructions, post-operative care instructions. You go home, if you got a pillow, you prop that arm up so you can reduce the swelling. When you go to the clinic, you have that nurse change that bandage and listen to it for you. And then you ask them, how do you listen? If the surgeon or anyone from their office didn't tell you how to check, then you ask the nurse at your dialysis unit how to check for the bruit and thrill to make sure your access is still working. And then you got the maturation process. And what that is, once the newly created AV fistula or AV graft is done, it needs time to mature and develop a strong connection between the artery and the veins. Now, the maturation process usually takes about 6 to 8 weeks, during which the person continues to do dialysis through the catheter, and you working to exercise that arm, trying, if you got a fistula, trying to build the vein up so it'll be able to take a needle, because that's the reason why you're trying to build that vein up, so it can handle these type of needles. Brother Moses, anything you want to say about the maturation process?
Sorry?
Anything you want to say about the maturation process of a newly created AV fistula or AV graft?
Yes. Many a times we warriors, we don't take seriousness when it comes to exercising the graft, because you do it on day one and you get tired. Yeah, and then failure rate is also high. Failure rate is also high, especially those who are newly on dialysis. So I've seen failure rate is very high. Mine failed; it never matured. I didn't know that I need to exercise. I thought I would only exercise for a few hours. But then it was just because the veins were narrow. That is why later on there was a recommendation that I have graft. So
Okay.
yeah, but again, failure rate for is success. I mean, the failure rate is I was told is 40%.
Oh, really?
Yeah.
Okay. We had a couple of comments as we coming really close to the end of the show, but had to finish up. Two more concepts. So David Rollins, he said in 2021 he had surgery to move his access, and the doctor clipped something that caused him to have a code, meaning go unconscious, his heart stopped, and he stayed in a coma on life support for 4 days. And he says he wished he would have asked all the right questions before he started. That's what I'm saying. Asking questions is very important. And this is the same David Rollins that just recently got a transplant. 2021, you see how he didn't give up. 2021, he was in a coma on life support for 4 days. 2 years later, he's had a successful transplant. Brother Moses, Tabitha said she will follow up for you and get my number and we'll connect with you.
Thank you so much, Tabitha. Let me just share my screen. It is something I've never done. Let me just share my WhatsApp screen because there are two people. They have just messaged me that I should direct them to you to have it done by NIHF. Two of the patient. Let me just a minute, please. I want to share it. The request. Wow, it's not coming up. It's not. Let me just share. Okay. Let me just. Not able. I'll just Tabitha, kindly share your contact on screen so that
either that or she could
put it
in the comments.
Sorry?
I said she could put it in the comments after the show.
Yes. Okay.
Mm-hmm.
She can put it on the comment section, and then we can also do a follow-up and help other fellow warriors if there is a way that it can work.
Okay. So let's talk about, I'm sorry, brother. Was you going to say something?
Yeah, I was just still trying to share because I'm also on was up right now. I wanted to share so that, all right, I'll just do a follow-up.
Yeah, right. Put it in the comments, Brother Moses.
All right.
Put it in the comments.
Okay.
Yeah. So let's talk about something that's optional that happens for many patients with an AV fistula or graft, and that's a fistulogram. And in some cases, a fistulogram, which is an X-ray procedure, may be performed to evaluate the AV fistula or graft's function and possibly identify any potential issues such as narrowing or blockage. Now, for many warriors, you may have had this done already. Your access, they may have to send you to the access center because your access is narrowing. Number 7, then after that, through this process, it's finally time to use your access. And so once the AV fistula or AV graft has matured and is deemed suitable for use by the surgeon, the patient can start using it for hemodialysis treatment. And see, that's where the first time you start using the access. Now, if you got a fistula, we do 1 and 1. We put one in your fistula, and then we use the other return line in your catheter. So you got one connection here to return, and then we use your arm for the blood coming out. And most times it works. Everything is smooth. But you got some cases where this is where you find out that the veins haven't developed. When we start having issues with the stick, we put the smallest needle in and the vein is collapsing. This is where you find out you had issues, multiple infiltrations. And this is where regular monitoring and some places maintenance of the access sites are necessary to ensure long-term functionality. Now, this is why they have these access centers, because if you have a fistula and your veins are small and they still manage to do something, you may have to go time to time to get fistulogram done. And let me just say this before we close the show. It's important to note that the specific process of what we talked about may vary based on individual patient circumstances and healthcare provider practices. That's why I say get a second opinion. It is always recommended to consult with a vascular surgeon for personalized guidance and information about your situation. Because again, everybody's situation is not the same, especially when it comes to getting a lifeline or access put in your arm. Brother Moses, before we end this broadcast, is there any words you would like to say about what we talked about? Okay, Tabitha put her information in the comments, brother. So you see it? I have it on the screen.
Thank you so much, Tabitha, to have your
And then when you
contact.
go to the show and the Feagle Initiative, you can see in the comments as well after the show. But here
Thank
go
you
our
so
number
much.
right here.
Thank you so much.
But any last words about this whole process of
Oh, yes.
getting the access before we head out?
Oh, yes. The backbone of everything is getting educated, trying as much as possible to learn and understand your condition. More so, when you go to see a doctor for any kind of surgery, you can always prepare your notes. I mean, questions to ask the doctor so that you don't forget. I know people go for second opinion, but coming out of the doctor's appointment, then they remember that they must have forgotten this and that and so on. So if you are a warrior out there and you intend to do any form of surgery, or you want to just generally seek second opinion, very important that you put your question so that you don't forget. Thank you very much, and I'm glad everyone is watching wherever you are. We are very happy. We appreciate you for supporting this program, Kidney Hub East Africa. Thank you very much, Tabitha, for connecting. You've made our show lively, and we also appreciate your effort. If you are a nurse, please try as much as possible so that we can also get good insights from you and the rest of the community. We highly appreciate anyone who has our feedback. Thank you very much, and welcome again as we meet next Sunday, same time, same hour. I'm your host, Moses Kennedy, your kidney ambassador. I'm your co-host, Moses Kennedy, your kidney ambassador.
Next week, we may have to have a schedule change for Sunday. I'll let you know, Brother Moses. But yes, Tabitha, we would love maybe to bring you on the show if possible one Sunday to talk about the healthcare part of dialysis, wherever you're at. But thank you, Tabitha. It's a very informative program to our client. Well done, Steve and Brother Moses. Thank you for watching again, Tabitha, and please encourage your patients to watch the show. This is for them. Any questions they may have, they can send through you or through the show, and we can definitely get their questions answered. And you're welcome. Thank you for your support as well. So, Brother Moses, another show. Hopefully, if we do come back next week, it may have to be a little later in the evening. We'll discuss that. But we'd like to thank everyone for tuning in today to see the process of getting the AV fistula or graft. So if you find yourself in this situation, you can come back to this video or reach out to one of us just to see the process again. So you'll know once you go to the surgeon what questions you may need to formulate and ask them based on your situation. Find out if your veins are small. If they small, what's the alternative? A lot of people don't know that you could put an access in your leg, right in your thigh area. But it's going to probably be a graft. But a lot of times, for people who got small veins, they end up getting a graft put in their thigh. So now you don't have to worry about the use of your arm. You got the use of your arms, because for many people who got multiple accesses in their arms, they may have numbness, weakness, can't really grasp an item. So if you have it in your leg, at least you got use of your arms. So with that being said, Brother Moses, thank you again for coming and adding another perspective, viewpoint from Kenya, and hopefully we'll be here next week on the same time, but if not, we will let people know the time change. So we'd like to thank everyone for watching. Have a great week. If you go to dialysis tomorrow or Tuesday, have a safe treatment. Brother Moses, you go to dialysis on Tuesday, right?
Yeah, Tuesday, Friday.
Tuesday and Friday. Okay. All right, brother. Well, be safe, and we'll see everyone soon.
Thank you very much.
All
Have
right.
a great day.
All right, brother. You too.
Thank you.